So, as this quote demonstrates, there's obviously some crossover between LGBTI ageing and people ageing with HIV. We have entrenched discrimination in society leading to second-class citizenship, the absence of children in most cases, the lack of close family relationships due to homophobia, as was referred to by Michael Kirby this morning, and in many cases they're likely to be single in old age. And I acknowledge the great work that's being done by the LGBTI Alliance, Health Alliance in ageing in the Silver Rainbow Project, but when you consider that 30% of people living with HIV are not part of the LGBTI community, it's not that simple. So there are 27,000 Australians living with HIV in Australia. Thanks to the arrival of antiretroviral drugs in 1996, HIV is no longer a death sentence and it's now a chronic manageable condition. And you can see that blip in the chart around the mid-90s there is represented by that change where people stop dying. People with HIV are growing older and along with the rest of Australians. The average age of Australians living with HIV is now over 45 years of age, and by 2020, 50% of all people living with HIV in Australia are going to be over the age of 50. So we're doing a great job of stopping new infections, but people with HIV will continue to age and it will become an increasingly older population. Added to that, we're beginning to see the early development of diseases commonly associated with ageing in people living with HIV. We're going to see more people requiring increased community and then residential and then high-level care. It seems that many people living with HIV will end up in aged care at earlier ages than their HIV-negative peers. We know that people with HIV are experiencing accelerated and accentuated ageing, either because of the disease itself, or because of the drugs, or a combination thereof. Most people with HIV in residential care facilities will also have a number of non-HIV medical conditions, for example, dementia, diabetes, heart disease, high blood pressure, chronic lung disease, osteoporosis, and certain types of cancer. And there are no clear answers as to why these non-AIDS comorbidities more often affect people with HIV. We do understand the factors that are contributing to it, and that is the toxicity of the drugs, lifestyle factors, immune dysfunction, and inflammation. And of course, this has implications for home care provision, for residential care facilities, for the medical profession, for the welfare system, for research, and for organisations like mine who represent people living with HIV in Australia. And moving beyond the purely clinical, HIV is an infection that many people have ingrained fears, prejudices, or negative attitudes about. Stereotypes about what people with HIV are like can lead to stigmatising attitudes and discrimination. People who work in aged care are just as likely to hold those stigmatising attitudes or display abusive behaviour toward people living with HIV as anyone else in society. People born overseas are likely to carry attitudes to HIV that are prevalent in those countries. And because it is so ingrained, it's not always recognised as discriminatory by those who perpetrate it. Added to that, we know that 58%, yes, 58% of over 50s living with HIV have moderate to high levels of HIV self-stigma. If you stigmatise yourself, you tend to validate the discrimination that you receive from others. Of course, some stigma comes from a lack of experience or knowledge, and some people do have irrational fears of infection. But is there actually anything to worry about? The risk of HIV transmission in some common scenarios in aged care is very low or non-existent, as you can see on this chart. If a person has an undetectable viral load because they're on treatment, it is now known that it is impossible for them to transmit the HIV virus to their partner even during unprotected sex. So you can imagine in other less intimate circumstances, there is obviously no risk of transmission. Aged care workers, like all healthcare workers, should use standard precautions for all patients, whether HIV positive or not. Standard infection control precautions are sufficient to protect workers in all circumstances. But sadly, that's not what happens in practice. In a 2013 study of staff at the Royal District Nursing Service, which provides home and community-based nursing care to people living with HIV, a significant proportion of staff were concerned about contracting HIV in the workplace, even in no-risk situations. 22% said they were concerned about contracting HIV from drinking from a cup in a client's home. They expressed unease about whether a pregnant staff member should visit HIV-positive clients. A significant number support the use of computer alerts regarding HIV clients, which they justified in terms of infection prevention. 20% said they would use special measures with HIV clients they would not use with other clients. 18% said they would use gloves with every aspect of client care, including history taking. An alarming 72% said they felt they had a duty of disclosure to disclose an HIV-positive client status to another nurse. And randomly, 7% said they would disclose a person's HIV status to a council worker. These practices are either active discrimination or indirect or passive discrimination. It's abuse. People with HIV should expect to be treated with dignity and respect, and their care to be free from rejection, exclusion, and insults or gossip. These are some other examples of elder abuse towards people with HIV, but a case study will illustrate the point more dramatically. Bill was living as an inpatient in a ward in a hospital. He'd been diagnosed with HIV late, and he experienced some health complications. After commencing HIV treatment, his HIV viral load became undetectable. He needed to be discharged into a residential home to support his general care needs. The first care home refused to take him, stating that we don't deal with people like that. He was later refused on the grounds of infection control and risk to staff. Finally, the third home that he applied to offered to take him, but that wanted to double the charges because he was a burden. After 4 months, he was still waiting for care. Now, thankfully, there's something being done to address this, and the Australian Society of HIV Medicine, ASHM, has released a training program for care staff, and in launching the program, Ita Buttrose said the program aims to ensure older men and women with HIV that their needs will be met when they are seeking aged care services. It will also help remove the barriers that in the past might have excluded or discriminated against them and their aged care needs. And that's doing a great job to eliminate the fears of people living with HIV, but there is still significant fear in the population. People fear ending up in nursing homes. They fear that they won't receive adequate treatment, that they'll be stigmatised or discriminated against because of their sexuality or their HIV status. Their fears about complex comorbidities, about the effect that HIV has on the ageing process and on their independence, fears about isolation and loneliness, and they have limited financial resources. So in responding to all of these issues, my organisation has developed an advocacy agenda for ageing with HIV, which includes the following components. Firstly, assistance navigating health and social care services later in life. How does NDIS and My Aged Care, for instance, meet the needs of people ageing with HIV? Secondly, medical services to address HIV in the ageing process. How do we encourage GPs to screen for cardiovascular disease and pre-diabetes? Thirdly, increase surveillance of medical conditions common in people with HIV over 50. Fourth, prevention and lifestyle advice for people with HIV over 50. And finally, consumer empowerment for people with HIV already experiencing comorbidities. We certainly need to empower people ageing with HIV to recognise elder abuse and to expect their care to be free from stigma and discrimination. Thank you.